We are on a mission to save and revitalize independent pharmacy. On the Catalyst podcast, we dive into current events that are shaping how pharmacists approach their patients and their businesses. Fuel your passion for pharmacy, one conversation at a time.
3, 2, 1, 0. Ignition.
Welcome to the Catalyst Pharmacy Podcast. I'm your host, Mark Bivins, Vice President of Sales for PioneerRx, and today I'm here with Josh.
Hi, I'm Josh Howland, Vice President of Clinical Strategy.
And today we're here with Shelly Spiro, Executive Director of the Pharmacy HIT Collaborative and President and CEO of Spiro Consulting. I'm usually Josh's work wife, so just FYI.
And travel partner. Usually we go to trade shows in twos, and Mark and I initially bonded over some tacos about 5 years ago.
Yep. And
have been to...
the origin story.
Yeah, like a million different trade shows together. And we devolved from taco buddies to trade show buddies to work spouses. It's one of the best, most fulfilling relationships I've ever had.
Everybody listening is like, God, this got weird.
I'm just glad I don't have to travel right now.
Yeah. I'd say you probably travel a lot for your role as the head lady over there at the Pharmacy HIT group. Right? I
did prior to the middle of March 2020.
That's funny. Like, all of us kind of remember, like, my last flight was the second week of March 2020, right before everything shut down.
Yeah, that's right. You especially.
Yeah, I flew in from Pittsburgh that weekend, and then they shut down DFW.
Yep.
That was the last flight I've been on.
I don't even remember.
Yeah, I was in Orlando for the HIMSS meeting, and it got canceled. And so I had to fly back from there on March 6th.
I was thinking about the other day, I really missed the quarterly live get-togethers. The calls are all right, but man, there's just no substitute for getting 30 people in a room that you see, once or twice a year.
Yeah.
Man. Especially in DC.
Shelly, where are you out of? I heard Vegas, but I've also heard DC.
I'm out of Las Vegas, Nevada, which is my hometown.
Okay.
I've been here since March 6th.
So are you from Vegas or?
I am.
Oh, wow.
Yes.
I've never actually met anybody from Vegas. I've met people who lived there, but no one who's been from there.
Well, I moved here in 1955, so I guess that would be consider that I've been here. I was not born here, but
I think you can.
My parents moved here.
Yeah, I think you can claim it. I think you can claim that as your hometown for sure. Well, how did you get started in the pharmacy? What led? We like to kind of discover that with everyone, but how did you get into it?
Sure. Well, I'm a pharmacist. I've been a pharmacist since over 40 years, since 1976, and I was always involved in looking at things from a different standpoint. How could you look at processes and how can you do processes better? And back at that time, they really didn't have pharmacy informatics. And so I started to work with our pharmacy system vendors and just began to become a super user and really enjoyed making changes, especially because I have a long-term post-acute care background.
Okay.
So especially in long-term care, this was an area that was really needed. And we made some changes, and and I just pursued that. When I left Kindred Healthcare, which I worked for, which I was, when I moved there corporately, I was a senior director of health IT, what we called information systems, government affairs, and compliance. And so that fit nicely into what I really enjoyed doing. And when I opened my own consulting firm back in 2005, I just continued down that route of pharmacy informatics and doing more to really help pharmacists with pharmacy informatics. And then in 2010, the professional associations came together out of a Joint Commission of Pharmacy Practitioners initiative in 2010, and they formed the Pharmacy HIT Collaborative, and I was named the first and only executive director.
Okay.
Right. I've been doing this for 10 years.
You were also past president, right, of the American Society of Consultant Pharmacists, correct?
I was. That's correct. I was past president, been very active in ASCP since the 80s, and have been very much involved in all the efforts and still very active in ASCP, as well as many of the other professional organizations. I really believe as a pharmacist, it's important that we give back to the profession and really help with different initiatives. And this is I'm honored to be the executive director of the Pharmacy HIT Collaborative. It's been a real treat for me to give back so much to the profession and to make pharmacists more knowledgeable about health IT and what we really need to do in capturing clinical information and different workflows. And I have to say, Pioneer X has done a yeoman's job on making sure that those initiatives are embedded into your software, and you realize the importance of not just the dispensing portion of pharmacy, but moreover the clinical documentation.
Yeah. So one thing I think was surprising to me to learn about for the Pharmacy HIT Collaborative is really kind of what it is. It was one of those groups that I'd never even heard of until I worked for Pioneer. So for the people out here that are like me 2 years ago, just kind of tell us what Pharmacy HIT is built to do, and it's kind of the cross collaborative of all the people that seed it.
Yeah.
Sure. Well, as I said, it was formed in 2010 by the National Pharmacy Professional Associations, and in August of 2010. So we're actually going into our 11th year. And then we opened it up to associate members in November of 2010, and we wrote our roadmap document, which had 100 strategies of what really was an environmental scan of where pharmacy really needs to be. But the main mission of the Pharmacy HIT Collaborative is focused on pharmacists that provide clinical services and how those clinical services are integrated into the national health IT infrastructure. And I think that that's the really important piece. We don't really get into the dispensing side of pharmacy, okay, but really looked at as how pharmacists can integrate using and leveraging health IT. I actually wrote a paper on what we call digital transformation in the pharmacy for clinical pharmacists. And what digital transformation is really changing your business and leveraging technology to do your business better. And that's how we really approached the Pharmacy HIT Collaborative, was looking at what we really needed to do from a pharmacist standpoint with clinical services, and how can we standardize, bring the standards towards that, and really begin to develop the coding system that we use, such as the international coding system and the standards that are out there, the HL7 and NCPDP standards that are out there, and how we can leverage those so that pharmacists can standardize the clinical collection and sharing in an interoperable way information and data that they're collecting. I hear this so many times and especially from pharmacy vendors, we have to connect to another system and write an interface to another system. It becomes very, very difficult, time-consuming, and costly for the customers of vendors to do that. And we had some pharmacies that are trying to document in 15 different systems on the clinical side for MTM services and connection with other types of payers and other types of programs. And it just became too onerous for the pharmacist to provide those clinical services. So we had to work with the pharmacy profession and others to build the type of payment model to make sure that pharmacists can be paid for those clinical services. But instead of really forcing technology on our pharmacists with different types of technology, if we could just standardize and leverage the standards, we would be able to maximize the productivity of pharmacists in their practices. So it became seamless. Now, this is not a unique type of situation. We saw this a lot years ago on the dispensing side. When the pharmacy dispensing systems, I mean, I'm an older pharmacist, so I remember filling out a claim to all the different payers until NCPDP came about with the universal claim form, which then standardized the claim. So the pharmacists, especially the system vendors, were able to focus on the workflow in relationship to the dispensing functions, which made the pharmacist more productive on the dispensing side. So we took that same type of concept. If we can get pharmacists to work with their system vendors on building out the clinical functions within their system and focus on the workflow. So JCPP, the Joint Commission of Pharmacy Practitioners, I think it was back in 2013. Okay. They created the pharmacist patient care process, which are steps that are used and to make sure that pharmacists are capturing clinical information in a standard way, because we had pharmacists that were collecting information following SOAP notes and trying to document into other clinicians' EHRs, and it became just too cumbersome for the pharmacist to use. And so we really tried to work with system vendors, find a model of which we did with Community Care in North Carolina to really test the model to see if we can get the pharmacist, no matter what system they have, because we want to be vendor agnostic and make sure that those pharmacists were able to capture information in a very standard way, but share that using the nationally recognized standards. And I think we were very successful as Pioneer RX has been one of the more successful system vendors for pharmacists documenting clinical services.
Yeah. The fun part about the JCPP, and I'll give a shout out to one of my old pharmacists, Mimi. Mimi's biggest, I think every slide deck she ever built had the JCPP process wheel on it. It's got a little wheel with 5 sections.
We miss you, Mimi.
We used to give her a hard time about that.
We call it the wheel of life.
The wheel of life.
Okay.
That's fitting. Yeah.
All right. So it sounds like where NCPDP attacked kind of standardization of how to submit and dispense in a technical way and getting paid for the format and transmitting that data. You guys are looking at it let's do the kind of, and I'm going to oversimplify this to a degree, Shelly, same way, kind of the same approach NCPDP took, but let's try to standardize the way data is captured, transmitted, and payment models are applied in a clinical services environment with pharmacy.
That's correct. But there's two very important pieces. Number one, NCPDP standards are not really meant for clinical documentation. Right. But we harmonized with HL7. So we did the work at NCPDP and brought that work to HL7. And this was important because going back to the mission of the Pharmacy HIT Collaborative, we wanted to make sure that we were integrating into the national HIT infrastructure. So organizations like ONC, the Office of the National Coordinator for Health IT, CMS, were writing into regulation the use of HL7 for hospitals and physicians' offices, if you remember the Meaningful Use Incentive Program. And since pharmacy was not part of that, we still thought it was important to integrate with the same type of standards that the national organizations, the government organizations nationally were touting that we should be using. And that's how we came up with the Pharmacist Electronic Care Plan.
Right. And that's one of the things to think about is historically pharmacy and health, and I almost want to slap myself for saying health, pharmacy and medical insurance have operated in two different worlds, and pharmacists and physicians have operated in two different worlds. It would almost be like in the internet of having to think about, well, I want to send this email to this person and having a whole different language, giving using those same types of, HL7 and SNOMED codes. It allows you to send that to anybody that can receive it. So it's the beauty of email. You can send it to anybody. Right. It just works because it uses the same standard. This is the same idea, right? Being able to share clinical content over the same standard with anybody who also has a computer.
Right. So the foundation of the pharmacy e-care plan started here.
Yes.
Right. Okay. Yeah, and we all know how much
started with me.
And we all know.
I could actually tell you where it started.
Oh, let's
talk about that.
CMS and ONC held a meeting for long-term and post-acute care.
Okay.
And this was back in around 2013. They started, they began to, as we began to look at the patient as the center of the model, that group came together and said, well, we need a plan of health for our patients, because the high-risk patients who are in long-term and post-acute care, home care and hospice and some of those other areas, weren't able, they were going from one provider to the other. And so the e-care plan was just beginning to come about within HL7, and they tagged on to that, especially for chronic care management. And chronic care management, CMS was paying physicians for chronic care management under the team-based codes. And their first aspect was actually to force the physicians to use an electronic care plan as a means for documenting chronic care conditions and or chronic care management. And it was interesting, and it was also related to transitions of care. But that's where they really started to push the e-care plan, and where we began to jump onto, we meaning the pharmacy profession, began to jump onto the pharmacist's electronic care plan, creating a profile that was specific with examples for pharmacists and the system vendors to get them to adopt what at that time was CCDA and the CCDA standard. But we were lucky enough because we worked with the Lantana Consulting Group, and that Lantana Consulting Group, which was part of an ONC high impact pilot, along with CCNC, and Pioneer RX was one also, that Rick Geimer, who was one of the co-chairs for the HL7 Structured Documents Work Group, they were beginning to work on CCDA on FHIR, which is really the FHIR standard. And it just because organizations such as yourselves really didn't have the older architecture built into an EHR, you picked up on FHIR really quick, because what it stands for is Fast Healthcare Interoperability Resources. They're pre-programmed concepts and ways of exchanging very fast. So before, if you're building a CCDA structured document, that could take you months to do the programming on it. But with FHIR, you can program within hours of what would have taken you months to do. And we were just lucky enough that we had that ability to be the test for CCDA on FHIR, and it's taken off from there. And we finished the Release 4 ballot back in May 2020. And we're moving forward as the government is beginning to write regulations for FHIR. We're right in step with what is happening with the other with government agencies and regulations, so we can be interoperable with other types of care providers and part of the care team.
Right. Well, interestingly, and maybe ironically, all of the pharmacy vendors, I think with the exception of one or two, adopted FHIR.
Yeah, we didn't do CCDA.
We skipped right over it. It was burdensome to develop. But the interesting thing is all of the EHRs were already embedded in CCDA.
Right. That's where we thought we were going to see some success when we were submitting care plans originally, when we first when we first cracked this out, and then we were like, oh, everyone's still using the old standard.
Yeah. Our initial goal was cool. CPSN is a great place to send care goals, but it can't be the only place. Right. So at some point, we're going to have to exchange information with EHRs and be able to consume and make clinical decisions off of that, or we've just created an extra piece of work. And then we find out that the EHRs are 2 years away from being able to accept FHIR documents. But Shelly, what do you think? They're getting closer, right?
Oh, yes. There is a huge, well, I don't know if you know this, but actually I was on the ONC, what they call Health IT Advisory Committee call today. We have a new national coordinator, Mickey Tripathi. And I've known Mickey for quite a few years, and he's very good. And CMS is beginning to write regulations now for fire. And more interesting, there is a huge project, and you probably know this, Josh, on the payer side with the health plans. I'm not talking about the PBMs. I'm talking about the health plans themselves with the Da Vinci Project to really leverage their technology to capture information directly from EHRs. And we're right in step with the Pharmacist Electronic Care Plan, which fits nicely into pharmacy models because we're used to dealing with payers and we're used to dealing in that particular type of a community because the physician's offices especially are not really prepared at this time to accept fire types of e-care plans.
Right.
And until they build out their workflow. But there is a push by the government, a huge push with the interoperability rule and the information blocking rule to really push those organizations to adopt the fire resources and the exchange of clinical information.
I don't want this to devolve into an hour long of nerding out about IT, but once you
what we do.
Yeah.
That's kind of what we do.
Sorry, that's what I do.
Kind of what we do here in a way.
We live that. But, one of the things that kind of is on the mind, like I see a lot of research around it as well, is once you can share that information, you create a new problem, which is what do you do with it? Right? Imagine if you're imagine if you're Epic and you're getting MedList updates for patients from, say somebody goes from a hospital inpatient setting to a post-acute care into an LTC and then maybe back to the hospital in that 30-day window. You could potentially have 4 care plans just with that. And then you have pharmacy care plans come in. So now you've got 6 or 7 different lists of allergies, 6 or 7 different lists of health conditions, med recs that have happened 5 or 6 times. So you have the single source of truth problem that we still have to solve.
I totally agree. But once I think those organizations realize that a pharmacist has reconciled the med list and there's some trust that goes with, and you have actors that you can identify where that care plan came from, that you're more apt to take that information as the source of truth. Now, any organization that's receiving information is going to have to do some type of reconciliation, whether that's immunization reconciliation or medication reconciliation, allergy problem list. They're all going to have some type of reconciliation process that they go through. And so that's something that even pharmacists are going to have to deal with that also. So it's not anything new to what we're doing from a paper standpoint as opposed to an electronic standpoint. We just have to work the workflow of all of that information into a dashboard that's going to help those providers do that type of reconciliation.
Right. Yeah, it's just you were drinking from a slow-moving fountain before, and now you're drinking straight out of a fire hydrant.
Well, but again, you're drinking out of a fire hydrant in a manual process. The issue is you're not paying attention to the information that's coming in, whether that's verbally or electronically or by paper. And so there's nothing new to that. But we think that by leveraging the technology portion, you can then adopt machine learning or artificial intelligence to weed through some of the areas so that your algorithms are actually set up in a way that you're receiving the information. That's what the vendors have to begin to do. And they haven't, and I don't mean Pioneer X, I mean the large EHR vendors.
Yeah, we'll take it though. Yeah.
And that was in our last pharmacy HIT meeting that I went to. I missed last one. Sorry about that. I'm in trouble.
Shelly's yell at you.
But, one of the things we talked about is we found, with the care plan specifically, if they're not integrated into the workflow, they just don't happen.
Yeah, they don't. Not at scale.
Right. And a lot of those is we'll be able to receive all that information and be able to distill it down and be like, all right, here's the 5 important things. Okay, go. That's really the beauty of what we can do from
Right.
an IT perspective.
So in the sense of like, now most of our audience here is going to be community pharmacy. So in the sense of like how it could impact a community pharmacy, you're Shelly, kind of what I hear you saying, and maybe Josh too, is system vendors will have to start figuring out or creating rules engines of going, hey, I trust this because this is the doctor, so I'll allow it to update diagnosis codes, but I won't allow it to maybe update X, Y, or Z, or put it in a queue for them to review, to look at that. Is that kind of what I'm hearing?
Yeah, or maybe you could use some probabilistic matching. Say if you get 3 care plans from 3 disparate groups and they all have the same, they have a diagnosis code of E11, that's probably okay. You can trust that patient has type 2 diabetes. And yeah, I remembered that it's E11.
Yeah, I was just saying, I don't know what any of that means. But yeah.
Well, but it's no different than what we have today with paper. I mean, you can get a PDF or a fax or something that's coming into you. What do? You just file it away. You don't even look at it. So until we can consolidate the information into dashboards or usable information, this is one of the reasons why you haven't seen the physicians' offices and even some of the hospitals do a good job of input of information. They do a great job of sending it out, but they don't do a really good job of bringing information into their
frankly,
systems. Yes.
Even all of the pharmacy vendors, us included, we're great at sending them out.
I think that's
we don't
everybody's
receive any of
struggling with
them.
that. We're doing it better now with e-scripts and things like that. But you're right.
E-script's not a problem. But if we needed to receive a care plan that wasn't ours,
okay. Right.
What are we going to do?
We can send them all day.
It's going to start coming, and this is what we'll have to be thinking about. And one of the things that we're promoting through the Pharmacy HIT Collaborative, especially with our system vendor partners, is you're going to have to start putting this concept into your development cycle. Because if you're going to be successful, that dashboard of information for the pharmacist to concentrate on those high-risk patients and where they could really make an impact and have positive outcomes and be able to get through quality measures in relationship to payment, such as a value-based payment model, we're going to have to start thinking in those terms of how we receive information and how the pharmacists are able to view all of that information in a meaningful way.
So you kind of see this moving into, I know this is really around the clinical picture of the patient. Obviously, we're seeing it used as a mechanism sometimes for payment with some pilot payers and things like that. Is that kind of the original design when the e-care plan was designed? Or I see a smile and a grin and a shaking of head.
That's a definitive no.
or more of an information exchange, because it's kind of being used, I think, at times in the way where it's like, hey, this is a form of payment or payment mechanism.
That's more of the pharmacies don't really know right now how to speak a different language. So the medical billing, they're like, yeah, just if you send me a care plan, I'll count that as a payment. But it was not intended to do that.
Well, the care plan was really set up to share with the care team, to share information with the care team, not the payer. But we had a problem in pharmacy because our pharmacists didn't have a payment model for clinical services outside of MTM. And so it's sort of like the chicken and the egg, which do you build first? So, and I think that's what the CPSN network has done, is create a network for a payment model so that you can apply the right pharmacist resources to the clinical services that you want to be paid for. So it's not as much the strict payment of the claim, because there are different types of ways that you could get paid, such as in value-based payment models, you could be paid on a per beneficiary level payment per month, per year.
Like a per member per month, like a capitated payment model.
Right. Or a capitated rate. And so there are other different types of payment models, but if we didn't have something that was focused on the payment, we would never get the adoption by the pharmacists because they couldn't apply resources to it.
Yeah. Now, the nice thing that I think the next generation, and Shelly, you can tell me if I'm wrong or not, but I think part of the nice part of the as FHIR evolves is that the standard does have a place where you can put billing codes in that payload and then use that to generate, an X12, which is the medical billing claim. So you kind of get the best of both worlds where you can transfer information and be like, I did all of this clinical work. Oh, by the way, this next process is going to generate the medical claim.
Well, hold on to your hats because
Uh-oh.
there is more that's happening. That is an interim fee-for-service model. And so what is really happening is way past that. So there was a report that came out in 2010. It was called the PCAST report. PCAST stands for the President's Councils of Advisors of Science and Technology. And in that report, the vision is that providers would document everything that they needed in their EHR. And the quality and the payer organizations would come by and pick up that information and pay you based off of the value that you're providing. Therefore, you wouldn't have to create a claim. There would be no need to create a claim.
They're listening basically already, right?
I mean, that was back in 2010. That this concept came about, and that's what ONC and CMS has been driving towards, especially with value-based payment models, and what the Da Vinci Project on the health plan side has been trying to do. So you will definitely have something similar that CPSN does, is they'll come by and start pulling information out of your system or requesting information out of your system, and then it will automatically generate the payment for you with your contractual agreement with the different payers. And that model is not far away. There are tests of those types of models, definitely on the hospital and on the physician office side, and some of the accountable care organizations have begun those types of models. But we're still in a fee-for-service model, and that's why you're going to have interim solutions of coming up with the medical claim, which is what you're dealing with now, and how the clinical documentation meets the requirements for the X12837 professional claim, which is your medical claim.
Right. How close do you think we are to kind of going into that? Sounds like what you describe is like a data lake with a bunch of listeners for results, right? And value-based care going, hey, how did we perform in this patient population for this disease state or this network? And then doing payments based on that. How close do you think we are on the pharmacy side?
Well, we're a hell of a lot farther than any of the physicians' offices. I will tell you that.
Yes.
And that was our objective. Our objective was, if we can get pharmacists to adopt these types of standards and good clinical documentation, we wouldn't be left behind, as we were left behind on other types of medical claim type of processes. And so that was the intent. I mean, there was a point that we were on the cutting edge, but I will tell you right now, we're definitely on the bleeding edge. But you have to realize the health plans are focused on hospital and physicians' offices. And until we can move away from a PBM type of model that's a cost-based model based off of the dispensing of medications and become a true clinical model, this is why it's important to work with the health plans, and something very similar to what CPSN has tried to do. Right. It's going to happen, but at least we won't be left behind. At least we will have the systems and the processes and the technology in place to be part of the end solution that the government is looking at, so that they can budget appropriately for healthcare and provide good quality care, what they call the quadruple aim.
The quadruple aim. I haven't heard that.
So
what is that?
It migrated from
just dropping all sorts of terms out of me.
The initial part was a triple aim, and then about 5 years ago, maybe longer, they added it into the quadruple aim,
which is what? It's for
one fold better than the triple aim.
Nice. You're not going to make me go look up what. I know it's population health.
We'll put it in the content. We'll put it in the comments.
Quality.
The original one was cost, quality, and access, and I think the fourth one is patient related.
Gotcha.
But
okay.
It's basically the four main strategic imperatives for healthcare reform in this country.
I digress.
Thank you, Josh.
Thank you. Josh is good for that kind of stuff. I usually have to throw things. He's usually a really good repository of
I am a purveyor of random facts.
Of useful facts and sometimes useless facts.
I'm better at useless facts.
Real quick. So before we leave any of that stuff, so the pharmacy HIT collaborative, along with like CCNC, you guys were kind of obviously bleeding edge of e-care plan, how to document and stuff. And I don't know if I'll get in trouble, but we've sent, I don't know, over like million and a half e-care plans.
Almost 1.5 million now.
And along with pharmacy in general, sending a ton, you got to feel a little bit accomplished to a degree. I know that's 10 years coming, right? Or however long it took to get you there. But between you and everybody else that helped in that group.
Well, see, I'm a strategic thinker. I think what's going to happen in the future, not necessarily what we're doing today. And I think that's important from a technology standpoint, because as system vendors, you understand that you have to be prepared for what's coming down in the future. And that's what we've tried to do with the Pharmacy HIT Collaboratives, really prepare system vendors and pharmacists for what's going to happen. Because we were so far behind, not necessarily on the dispensing side, but on the clinical side, that we had to take a big leap forward. And we took a really big leap forward, and that's why we are part of the bleeding edge of this type of technology. But it's to assure that pharmacists will have value in the future. And if we didn't do this, look how far behind we would be. Mm-hmm. And I think that's really important. But don't underestimate, too, the Pharmacy HIT Collaborative 10 years ago, we started identifying the SNOMED codes and the coding that takes place so we can standardize that prior to giving that information to the system vendors as part of the care plan. And we built that into it. This is something that the other healthcare providers have not done. They have not begun to codify in a way to help the system vendors with value sets. You realize that the value sets that you use as part of the National Library of Medicine's Value Set Authority Center was originally set up value sets for quality measures. We utilized the value set, so we had a public place to put these codes so that any system vendor would be able to have access to it. And that's back to what Pharmacy HIT is trying to do in being vendor agnostic and allowing you as a system vendor to write the user interfaces and prepare a system that your customers want. And then you're not stuck with everybody having to use an Epic or a Cerner system.
Right.
Right. Well, and to kind of highlight the magnitude of that, when you go to build a care plan today, we may give you a drop-down list of 12 or 13 items, right? That's more than most pharmacists want, but that's what you need to describe the situation. If you didn't have somebody like the Pharmacy HIT Collaborative maintaining those value sets, the entire code base of SNOMED's, about 350,000 items now?
Yes,
it's
over that.
Right. It's an unsearchable amount of things to look for. So you're basically getting all of this repository of information of when I describe an encounter with a patient as a pharmacist, these are the 50 most common things I do. Right. That's huge. But more importantly, it allowed the pharmacy profession, like AMA did with CPT codes, to drive the correct standardization of clinical documentation so that they can oversee that portion on behalf of the pharmacy profession. And that's what came out of the ACT program, the academia, CPSN transformation, or I can't remember what the T stands for, but where the schools of pharmacy, and that's what Mimi Baker from when she was with Pioneer RX worked with ACP as creating this process so that as we begin to teach our pharmacy students this type of clinical documentation, begin to standardize that clinical documentation, no matter what system they're using, that they would be able to understand those concepts on a standard way of documenting and not have to fall into those processes that the physicians are doing, because the physician workflow is entirely different from the pharmacist workflow. The physicians are focused on leading to an assessment to a diagnosis, and pharmacist workflow look at the patient as a whole and all the medications they're on and how those medications work within the body of that patient. And so it's an entirely different workflow.
and we wouldn't do well in working on a physician-based software.
Right. And just for those out there, we are still working with AACP and Nidhi Gandhi to get that taught in more pharmacy pharmacy schools. Right now, we're in 24 of the 130
something like
pharmacy schools.
140.
140.
Yeah.
Yeah.
How do we feel about how do you feel about that number getting higher?
I feel like there's no chance that number continues to go higher.
Really?
I think in 5 years you'll see 20 or 30 of those pharmacy schools no longer accepting patients.
Patients.
I mean, and this is really important. I mean, when I went to pharmacy school, your lab was about compounding and mixing and preparing suppositories and tablets. The labs now within pharmacy schools are clinical based. You're meeting with patients and you're doing clinical documentation. This is critical to not only advancing but maintaining the profession of pharmacy,
right,
in all practice settings.
So you're saying is like you can't continue to either grow class size because of the material being taught, or?
Well, so I think there's two things. There are too many pharmacy schools that came about when they swapped from a BS in pharmacy to a PharmD in 1998, I think.
I remember the date.
They had basically a gap year of pharmacy students not going into the group, and then they went into a PharmD program, added another year. Then they started adding residency, so it artificially made it look like there were fewer pharmacy students coming out and more pharmacy positions opening up. And then that corrected.
Right.
And then you also had, you didn't need 8 pharmacists to run a Walgreens doing 300 scripts a day if you're just counting by fives and using robots, right? So the more robotics and more automation that came out, it just it just highlighted the fact that you don't really need that many pharmacists. So until there's a larger transition of pharmacists adapting clinical roles, which they can't now for whatever legal regulatory reasons, you just don't need that many pharmacists. And it's going to be hard to convince a kid to go to school and come out of pharmacy school $200,000 in debt and not have a job for a year. They're going to stop going. And some of them should, right? And there's just too many pharmacy students.
It's interesting. I hear that a lot, just in general. I didn't mean to like completely twist the subject, but I wanted to get your take.
I would drop like 20% of the pharmacy schools, but I don't get control over that.
Well, and really from the pharmacy HIT collaborative standpoint, that really wasn't our concern. Our concern was to have a standard way to document the clinical services and make sure that we train our students for doing that, because we were training our students for clinical services. But when they get out into the community, all they were doing was dispensing.
Right.
And so this is where you get into the chicken and the egg, which one comes first.
Right.
But if you can't build the technology infrastructure for this type of model, it won't work. And that's what we really focused on and continue to focus on for clinical services, because we believe that eventually that pharmacists will be able to use their judgmental decisions on high risk patients and not have to work with and not have to focus on the minutia of some of the non-clinical services that we're providing. And we believe that this will save the profession. But more importantly, we were able to save the independent community pharmacy environment and setting. And this was important because what we were finding, especially with the larger chains, is they were focused on the dispensing portion, and it would become cost prohibitive for some of the community pharmacies to continue with and compete with some of the larger chains. And this way, it allowed the community pharmacists to really focus on community services, clinical services within a community pharmacy, because we believe that this is where the government really wants to focus on, especially in the rural areas and the underserved areas where we are really seeing high risk patients.
Right. And, that ties, this is why working with AACP makes a ton of sense, right? You want the kids coming out of pharmacy school to be trained to do that. You want them to go into rotations with doctors, nurses, and all the other groups in those care teams that are already doing those things. all speak the same language, all come out expecting to work in a team environment. And when they graduate, you don't want them to be happy counting by fives, right? You want them to push the envelope of this is what pharmacists should be doing. So I think all that alignment works really well. You have to have the infrastructure. You have to have the people that expect to do those things.
No, that makes total sense.
I kind of want to hit on the pharmacy HIT and, like, so your son's involved as well. How did it become a family affair?
Yeah, it kind of became a family affair.
Well, I don't know if you know this too.
Like
my daughter,
HIT royalty.
my daughter and son-in-law are also pharmacists here in the Las Vegas area. My daughter works for Optum Care on the long-term care side, and my son-in-law works for hospital pharmacy. But in 2005, when I left Kindred Healthcare and I formed my own consulting firm, that's how I'm under contract with the Pharmacy HIT Collaborative. They just bought all my time. And so we are a family-owned business, and my son is is one of the vice presidents of our consulting firm, and he manages he's our associate manager our manager for the Pharmacy HIT Collaborative. But my other son, I have 3 children. My oldest son works for SAP. So he's also involved in technology.
Wow, so you got a mix of pharmacist and technologist, and in some cases both in your family. Nice.
Definitely.
Deal. What do you guys do for fun? What do you guys do? What are you doing for fun? Do you even have time for fun? It sounds like you're so busy.
Well, actually, we just got 2 pandemic puppies. They're both sisters from the same litter. They are 11 weeks old tomorrow, and they are Maltese poodle mixes. And they're cute as ever, and they have been keeping me up all night. So if you see my eyes going slowly down, I'm still taking care of puppies. And actually,
would that be considered a multi-poo?
So I don't why we did this, I don't know, but we decided to help the world out and take on to adopting 2 new puppies.
Oh, that's cool. Yeah, we didn't do this in the pandemic, but right before it, we got cats. Your people are going to judge me, but I have like 2 dogs and 4 cats at my house. So I get what you're saying. I'm literally ripping up carpet because of it.
Yeah. I'm about to have to redo my floors as well for a rescue dog that we got like 5 years ago.
Yeah.
He has some separation anxiety, and when he's anxious, he will try to escape wherever he's at, which includes my house and the walls in my house. So hopefully with a couple of multi-poos, they won't go nuts on your walls.
No, you know what? They've been really good. And we talked about getting 2 because I think that helps with the separation anxiety.
Mm-hmm.
Yeah.
That they have each other, and so it's more normal for them. And not that I really wanted 2, but I really felt it was important that they happened to be available, and 2 sisters, and we thought it would be good because they would be used to each other.
Yeah, I'm a big fan of having dogs in pairs. Like we've had 2 sets of dogs. We're on our 2nd set of 2 now, and they're both older rescues, and they're a little bit crazy, but they're fun. Also, as an interesting side note, there are some countries that won't allow you to buy just 1 guinea pig because they're so social.
What? I didn't know that.
Yeah, you're supposed to buy 2. Yeah, apparently buying 1 shortens their lifespan by like half because they're really lonely.
I didn't know
Yeah.
that. Countries regulate that?
Yeah, yeah. I can't remember.
Sorry, I'm not saying there's bigger fish to fry. I'm just.
I'll have to Google it, but it's a random country too that will not allow you to buy 1 guinea pig.
New Guinea?
It's not New Guinea.
Sorry,
that was the worst dad joke I've heard on this show so far.
I know.
So if you ever feel on the need to get a guinea pig, 2.
I don't think we're going to do guinea pigs.
Like we're done with the dogs.
This is our last set of dogs we will have.
I have said that.
I've said that twice.
I've said that the whole time I've had the farm that I have at the moment. We're like not doing this again anywhere. And I'm gonna impress you, Shelly. The country that has that regulation is Switzerland.
And he magically came up with that answer.
We have a great studio partner. Her name is Madison that finds all that information. We actually have the other 4 things that the quadruple aim is.
I will say they're
you guys were really close. You guys were almost spot on.
Yeah. So apparently the quadruple aim is improved clinical experience,
right?
Better outcomes, lower cost, and improved patient experience.
You guys got it. You guys were right.
I mean, nuts and bolts. Right. It's all about cost, quality, access, and patients, right?
Right. So,
right.
Although when I did my MBA, I had this, one of my professors was a retired physician, super, super smart guy. And he was like, this was back when it was still the triple aim and it was cost, quality, and access. And he was like, the Affordable Care Act is built as a foundation to do what? And everybody in there is like cost. And he's like, nope, it's access. You're all wrong. And we're like, okay.
Well,
and he's like, you know what you can't do? You can't improve cost and quality without messing up access. And you can't improve access without messing up one of the other two. So it's like that fast, cheap, and good,
right? Pick 2.
Right. And so that triple aim was kind of like, he's like, I don't think you can do all 3. And so far he's proven to be correct.
So I have a question for you.
I love this. I love it when our guests bring questions. I love it.
Well, I had heard that Pioneer X was sold to Red Sail.
Oh, okay.
Technologies.
Yep. No secret there. Yep.
And number one, wanted to say that's great. I was a QS1 user for 14 years when I was a practicing pharmacist. So glad to see that you guys are teaming up and in some way, hopefully eventually in the future. And just wanted to congratulate you and get your thoughts on what you think of the merger.
I'll let you go first.
I mean,
I'll go second.
So I think one of the things that was really cool about, in that whole merger process is usually in that M&A world, one of the companies that happens to, right? Somebody comes along and buys you, and some people may or may not have wanted that to happen. And that was definitively not what happened with us. We kind of got to pick our new masters. The executive team at Red Sail is really, really smart. Even when we met them, not even in a kind of sales environment, Craig and Francis, super, super smart people, great vision. And it aligned with what we wanted to do. So I've been super excited about it. I've been busier than I've ever been in my life, which is why my attendance at the HIT meetings has been spotty. But it's exciting. It gives us a ton of opportunity. And the aligned vision around the whole piece is really what we can do with the profession of pharmacy. And that's really kind of aligned with my personal incentives. So I've been happy and professionally excited and personally excited. So I think what you'll see coming out in the next couple of years will be really, really fun and foundational to what pharmacy becomes.
That's awesome. I'm very, very pleased to hear that, and anything that we can do to help you as part of the Pharmacy HIT Collaborative, we're definitely in support of that.
Yeah, and I've had a lot of candid conversations with just, in sales, people heard about it. Some people called and were like, hey, what's going on? Maybe pause for cause, whatever. But I'll say this, like Josh said, we got to pick where we went. So we literally said, we really want to make an impact in independent community pharmacy, like those 2 words for sure. And so we kind of got to go, no, yes, right? And because the Dixons, to their credit, could have put us out for bid. They totally could have and got the highest price and then said, see you later, go deal with it. But they were nice enough not to do that with us. And really the whole point of coming together is trying to take a big swing at what the future of independent community pharmacy looks like, and that's still dispensing really, really well, doing that as efficiently and as good as you can in a pharmacy system while layering on like clinical services and other revenue streams for them. We know margins are shrinking.
Right.
And if we don't expand margins again, then I think we look back and we say we failed.
Yeah. I mean, and one of the things that we looked at before this whole thing came around was we knew what we were doing is exciting for Pioneer users. And we knew we needed to be about 2 or 3 times the size of what we are to be able to have the impact in the industry, especially when you're comparing to other PBM-owned pharmacies. Mm-hmm. And we didn't think we had the time to get there organically. So it was kind of a, when you can take a shot, you take it. And
yeah,
we did.
So it's just fun. It's exciting. We're learning to integrate.
Yeah, right?
I'll say that. We're learning. I'm learning. I've never done this before, or the big merger like this, and things like that. So I'm learning. Right. And so everyone, if anyone's listening that works with me, I'm sorry and be patient.
Growing pains are real, but they're fun.
We hope that this will help also with the Pharmacist electronic care plan and continue on in the clinical service arena for the independent community pharmacies. I think that this is important moving forward. And truthfully, the more that our vendors consolidate, it makes it a lot easier to work with the larger EHR vendors, as we've seen with some of the larger chain pharmacies.
I could see that, where if you're chasing a fragmented market all the time, it could be tough.
Right. I mean, and that's the same reason we hear from payers and manufacturers talking about, well, I know, I understand the thought that an independent pharmacy provides better clinical care, but I can't contract with 60,000 of you. I can contract with 3 people. I'm going to pick the 3 biggest contracts I can get. And that's where, CPSN adds a ton of value as well, but I couldn't imagine trying to herd that many cats.
It's hard.
Yeah.
It's very hard. So what role will Jeff be playing in the
That's a good question. He's still over Pioneer. He's not going anywhere. He tells everybody, I'm not going to be on a boat after this. And the whole point of pursuing this, and he led it too, along with us, but and the rest of the management team was, we feel like we need to do our part to try to make sure this profession is sustainable. And we feel like expanding margin through clinical services, helping them buy them better, adding transparency. He wants, I think he's been on record, he wants to get rebates out of the game. And so, yeah, he's probably more energized than ever. I'll say that.
That's great. Well, we're really happy for you. And again, anything that we can do to help, we're here for you.
And if you want to go back and kind of hear Jeff and Craig's take, I think episode 15 is where we did with Craig McEwen, the CEO of Red Sail, and Jeff. And I think Doug, it was.
Yeah, Doug Huey was the moderator-ish.
Right. Yeah, CEO of NCPA. And he has some hard-hitting questions. Yeah. So he was candid. So I welcome him. I'll have a candid conversation with anybody, to be honest.
That was candid.
Great.
Now it's my turn for a dad joke.
Yeah, all right.
I'll have to go back and listen to that episode. Then.
Nobody's laughing but me and you.
Yeah, it's cool. And I hope, as we get out of the pandemic travel mode, I'm sure you'll see and meet Craig. He's a super hands-on guy, really dynamic. I think 5 minutes of talking to him and you'll know exactly why he's the CEO and why he's the right dude.
Well, Shelly, thanks for being on, and really thank you for what you're doing and helping community pharmacy from your angle as well. We're walking behind them too.
And back at you.
Yep.
And
really to see the success of where we've come so far with like the e-care plan and where it's going, and man, it sounds really optimistic just talking to you. About kind of where things are going from either getting paid for clinical services or getting paid to manage a member.
Well, we are just the catalysts that make it happen. It really is all of your customers and those who are doing the heavy lift on all of this. We're just trying to keep you in line with what the government is doing. So,
you guys are the guardrails.
It's like
we're the guardrails.
So Shelly and Pharmacy HIT are kind of like the man behind the curtain. Yeah. It's like that this entity that nobody knows exists, but is really pulling all the strings.
Right, really the foundation of where we're trying to go with all of this kind of started with this group and a bunch of people tacking onto it.
And that was really the intent of the of JCPP when they formed us as the Pharmacy HIT Collaborative, was we support the profession in relationship to health IT. And all of our members. And so we're really not out there. That's why we don't hold meetings, large meetings, but we help support all the meetings of our professional organizations, and why I jumped at the chance to do this podcast with you, because you're a valued member of the Pharmacy HIT Collaborative, and we want to be there to support your efforts. I definitely want to thank the pharmacy profession and the professional associations for forming the Pharmacy HIT Collaborative, and also for Pioneer RX's participation as a member. And we appreciate you being here with us and helping us with these initiatives.
All right, Shelly. Awesome. Thanks for being on.
Cool. Take care.
Okay. Bye.
Bye.
Thank you for watching the Catalyst podcast. If you enjoyed this episode, please consider liking, subscribing, and/or following us. Give us a 5-star rating on Apple Podcasts to help us reach more amazing pharmacy people like you. Follow Pioneer RX on your preferred social media platform for the latest up-to-date pharmacy news and content.